Welcome back, everyone, to our continuing discussion on the ethics surrounding the COVID-19 crisis. And I think all of these issues are really because the needs are exceeding the resources. And these kinds of clinical decisions that we're all talking about, you mentioned some guidelines that you're using in endocrine surgery. There also is STS, utilization of our database to try to predict what resources would be utilized, such as ICU hours or ventilator hours. That's just recently come out and is a nice tool for us. But all of the other difficult decisions as far as ventilator allocation or who gets ECMO or who doesn't, those types of things, being referred to as utilitarian in the lay press. Is that really the correct terminology, Dr. Fenton? And are there any standardized guidelines really that we can use to sort of really point us in the right direction when we're making those difficult decisions?
I would defer the terminology question to Dr. Sade because I think he's much better at the utilitarian and consequentialist and all the different types of terminology. Sorry, can you repeat the other part of the question?
The other part is just, are there any guidelines out there that can really help us to tackle this resource allocation as far as ventilators and things like that?
I think there are a lot of guidelines that are being published. There are guidelines I mentioned earlier that the Ethics Forum put out where you quoted from about the ability of cardiothoracic surgeons, but there are guidelines within that document. And then there are a bunch of things. Hastings Center has put out a whole series of recommendations on resource allocation. There's a great article recently by Dr. Ezekiel Emanuel that sort of is an overview of the whole situation. I think the main point goes back to what Dr. Angelos was saying at the beginning, which is this whole issue of balancing out the individual physician's responsibility to the individual patient and then sort of all of our responsibility to the society and public health in general. And it's a hard balance.
Sure. To take it one step further, when we're talking about end of life type decisions or taking one person off of a ventilator to give it to someone else, Dr. Sade, in your recent paper that we referenced, you mentioned the concept of a critical care triage team. Can you tell me how that works and who it's composed of and how it functions?
Yeah, well, the triage becomes really, really important when you start running out of resources. And you have to decide who's going to get the resources that are available and who is not going to get them. And in many cases, that means who's going to be consigned to die and who's going to be live and who will live. In order to do that, there are several things that really need to be observed. First of all, you have to have a triage team. And this should have respected senior people from nursing, critical care, from intensive care physicians, from perhaps even a cardiothoracic surgeon thrown in once in a while, from several other categories of people. But they all should be fairly senior, and they should be highly respected, and they are going to be making decisions that will be very unpopular. And that's why it's so important to have the right people doing this so that their decisions can be trusted. Another requirement that I think is very important is that the people who are making these decisions, the triage team, should not be taking care of patients. People who are taking care of patients should not be making decisions who gets taken off a ventilator, even when they might do okay if they kept on the ventilator, but there's somebody else who has a better chance of surviving and for a variety of other possible reasons really should have the ventilator rather than you. So you are not going to have that ventilator anymore. You get taken off and it's given to someone else. Wow. I mean, I would really hate to be in a position to make decisions like that, but those are the kind of decisions that in Italy they've been making every day. And right now it's coming close to that in New York, and who knows where else we're going to be facing those kinds of decisions. And certainly the person who's looking after the patient needs to be totally dedicated to doing whatever is best for that patient. needs to be that patient's advocate, and therefore should not participate in any way in making decisions about triage, who should be given a scarce resource and who should be denied that resource.
I think that's a really valuable recommendation. Dr. Angelos.
Yeah, no, I was just gonna completely agree with Dr. Said's points. I think that they're really important. And the one additional thing that I would add is that these decisions that are being made by the triage teams, I think as much as possible should be made on the basis of some objective evidence of, the likelihood of recovery. And most hospitals have come up with their own mechanism for doing that, whether they're using SOFA scores or some other scoring to assess the likelihood of recovery. But what's absolutely critical, at least in my opinion, is that whatever criterion is being used, that be transparent so that the public understands why, these tragic choices are being made. And so it is not because we like this patient more than another, but it's on the basis of an objective criterion that we are applying in a uniform fashion.
Yeah, we have a recent paper that is currently in press in the Annals of Thoracic Surgery and the Journal of Cardiovascular Surgery, Thoracic and Cardiovascular Surgery. But that paper has been, because of its importance, has already been published as a preprint on CTSNet. And if anyone wants to look at that discussion and at the guidelines that we have in that report that Kathleen also participated in writing, then you can find it on CTSNet. If you go to the ethics, or what do you call that?
Well, perhaps, or there's also a section under the COVID-19 resources, I believe.
Yeah, it's also listed there. But I completely agree with Peter. One of the points that we made in that set of guidelines was that whatever the triage guidelines are, and we make some comments about what should be considered, but we don't tell people what should exactly be in those triage guidelines. The only thing that we say is that whatever triage guidelines you have need to be clear and understandable and transparent. That's very important, not only for public acceptance, but for doing the right thing at the right time for all of the patients who will be involved in this terrible series of events.
And what if you take the decision out altogether? There have been some centers who have considered actually making all positive COVID-19 patients a do not resuscitate, to either preserve resources or to protect their own staff from the danger of a code blue type situation. Does that fundamentally go against our oath as physicians?
I think it's a terrible idea, but let me ask Peter and Kathleen to comment on it as well.
I was actually talking to a couple of people at work about that because we passed around this paper. And the problem is that I don't know, and I don't think that we have the data, by which I mean medical data, to know what the survival would be of someone who presents in the emergency room in a near arrest, or someone who's on the ward, apparently not that sick, who has a cardiopulmonary arrest. What's the chance that that person would actually have a functional recovery after resuscitation? And I don't know the answer to that. And without knowing the answer to that, I would have a hard time saying that we should have a blanket rule to not resuscitate people.
Yeah, Dr. Fenton, I would completely agree with you. I think the problem is that the reasons that people have an arrest, whether they're COVID positive or not, are going to vary dramatically. And so we really can't categorically say everybody who's COVID positive is going to have a very poor chance of survival if they arrest, because you can imagine someone's COVID positive and they're coming in for a medically necessary time-sensitive operation, and they have an arrhythmia post-op, and they may recover rapidly if they get the appropriate resuscitations. So I think these sort of blanket crossing out of an entire class of patients is not the way to go.
I agree, and I agree.
Unnerving questions for sure. Dr. Fenton, this question is for you. You've spent a lot of your career in the humanitarian sector. Does this pandemic feel a little bit like some of those low resource countries where you're faced with challenges in personnel and resources, and you're sort of trying to do the best you can with what you have?
It feels a lot like it, except that it feels really weird to be looking at it on our own home turf. But the whole, I guess the more simple part of it is that many of us are used to accepting a little bit or a moderate amount of personal risk going into some of the countries where we've traveled, either because of infections that are predominant in that country, or because of violence related to organized crime or wars. I mean, we've certainly traveled in war zones where we were not free from risk. But the bigger thing, I think, is the whole resource allocation problem, and the idea, for example, that we go into a country for 2 weeks to be able to operate on hopefully 20 or 24 children, and there are 100 that come in that all need surgery. And we have to balance out this whole question of what's doing the best thing for individual children and what's doing the best thing for the larger picture as a whole, which is related to program development. So for example, there might be a child that is not likely to survive until we come back, but that's too complicated for the local doctors to operate on. But it's not really, operating on that child is not contributing to the program development, which is gonna, solve the problem in the long run. And those are hard questions to answer that are not unrelated to what we're looking at now.
Right, and speaking of war zones, like you mentioned, a lot of these kinds of questions that a lot of our colleagues are considering have been likened to war zones, especially in areas like Italy and New York. I'd like to, and as a final question, to get everyone's opinion on, do you think that we need the societies, ACS, AMA perhaps, to push for federal guidelines to allow some kind of counseling for all these clinicians that are facing these difficult questions that we've talked about, something that would be protected and not reported to the boards or to the credentialing committees? Dr. Angelos, what's your opinion on that?
Sure, I think it's a very important question. And, the evidence from the SARS outbreak in the Far East in the early 2000s, we have some evidence. There was a hospital in Singapore where 20% of their physicians and nurses suffered anxiety and depression after the SARS outbreak. And I would say that although that was bad, it's not nearly as bad as this seems to be, at least so far in places like New York. So it seems to me that we really need to provide whatever mechanism we have at our disposal to support caregivers, because I think there's a tremendous amount of moral distress that is going to be resulting, especially if we get to the point where we have to make these tragic choices about scarce resources. And I think that we will be doing a tremendous disservice to these caregivers if we don't provide that access.
Yeah, I think that's right. Another example of where the question has come up was after Hurricane Katrina in New Orleans, when there were a lot, they just ran out of everything. The hospitals were isolated. Nobody could get to them. They couldn't evacuate patients. They couldn't evacuate physicians. They couldn't bring physicians in. It was a horrible situation. They ran out of morphine. They ran out of really basic stuff. And the question is, what do you do with a physician who does the best thing that she can, and this actually happened, to treat patients even with the possibility that the patient might die because of the way they were treated in a way that was totally outside of ordinary clinical practice. That became a major issue at that time. This is now back in the early 2000s also. And there was a lot of discussion of passing new laws to protect physicians who did unusual things during crisis situations, such as we're now facing with COVID. And I don't think that very much came of that. And I think that that's a good thing. I don't think that legislation is the way to go, either to provide outlets for physicians taking unusual actions under extremely stressful situations, or to make legislation to require counseling for people who are having PTSD, providers, healthcare providers who are having PTSD because of all the stresses that they went through. I don't think that legislation is the way to approach that. I think that all of those things are needed, but we need to figure out other ways to make sure that everyone who needs help because of their involvement in the critical situations that many healthcare providers are going to be facing, that we discover and create ways to help all of those people without passing laws, which tend to be too rigid and really don't take enough into account.
I guess to clarify what I mean by legislation or mandated is, should it be mandated that that help is not recordable or discoverable by boards or credentialing committees every time you apply to a hospital and you need to indicate if you've received some type of counseling or some type of mental assistance? Is that something that we should eliminate in a situation like this?
Well, I thought that psychological counseling was confidential and didn't ever have to be reported. Am I wrong about that?
I believe that when you apply on credentialing committees, that they do ask you if you've had some type of intervention. I thought the medical board, it was reportable to medical boards as well, but I suspect I have to look into that, I guess. But speaking of this depressing category, can we end this really helpful discussion on something positive? Is there something positive that can come out of what we're learning and what we're navigating currently? Anyone's thoughts or wrap-up thoughts?
I'll tell you that we've seen a lot of positive things. The pace of research has been amazing, and the amount of international collaboration. Things are getting published so fast, and information is being shared across borders and across, all different kinds of opinions, that I think is really a great thing that I hope continues after this is over.
The other thing that I would say is I think that the increased awareness of the disparities that we have in how our patients have access to medical care and the impact of those disparities on their outcomes is something that I think is only being magnified and exacerbated by this crisis. But those disparities are there all the time. And I think giving us all a greater appreciation of those disparities is an important thing. And I think that we've seen a lot of people focus their energies on trying to address those disparities in a way that we maybe haven't seen as much in the past. And I do think that's a positive.
Yeah, I do think that there are other very positive things to come out of all of this. One of them is reminiscent of my personal experience and observations during a catastrophic event in 1989. That's a little over 30 years ago, when I was living in Charleston, actively practicing surgery at the Medical University Hospital, when Hurricane Hugo came through, a Category 5 hurricane that wiped out huge amounts of housing, wiped out hospitals. I mean, the amount of damage that it produced was incredible. That we've never seen anything like it before. I've been in a lot of hurricanes. I've always lived on the East Coast, and there are hurricanes everywhere on the East Coast, including Boston, where I grew up. But the thing about Hugo was that afterwards, and now I'm talking about after this is over, when we look back at what happened, after Hugo, the sense of community, the sense of people doing things together, of people helping each other, was way beyond anything that any of us had ever experienced. We were doing things for neighbors who we hardly knew before. We were doing things for them, giving them extra water. Everybody opened their freezers, which weren't going to be any good anyway in a few days because there was no electricity for almost 2 weeks. But everything was shared. Experiences were shared. It was an incredible sense of community that catastrophe brought together so much of the Charleston area, including local communities and the wider Charleston community. And I think that we're going to be seeing the same thing after this is over. It is going to end. It's not going to last forever. And when it does end, we will be able to look back at it and think about how we really pulled together in all of this. And we made things so much better for everyone because of working with each other.
I think that's a great way to look at it, both personally and professionally. So a nice summary to end on. Thank you so much. I feel like this input has been so valuable, and I hope that this resource, as well as others on CTSNet, will help us all navigate this uncharted territory together. Thank you.
Thank you, Emily.
Thanks, Emily.
Thank you very much.
Thank you.